Okay, welcome everybody. We're going to go ahead and get started here. So welcome to the Migraine Puzzle Masterclass, our series of figuring out the missing pieces to our migraine puzzle. So we have some amazing speakers today, and we're going to be discussing some of the most common issues behind migraines that just aren't addressed with conventional care. So that's kind of the theme behind our entire masterclass series. So if you are new to us, welcome. And I am Dr. Tanya Paynter. I'm a naturopathic doctor who I used to have regular migraines, daily chronic headaches, and now I've been 7 years migraine free. And I specialize in treating women with chronic migraines who aren't responding well or at all to conventional treatments. So I'm also the founder of Migraine Mastery, which is a 12-week group program that helps you to identify and heal the imbalances in your body that are causing your migraines, so that you no longer have to try to guess at what's triggering one, or if your medications are going to work, or that kind of stuff, all the things that we deal with, right? All right, so as you probably know, our migraine topic for this masterclass is love your hormones. So for my talk, I'm going to be speaking about the thyroid in migraine. So, this is a super, super important hormone that is often screened for by, when you first start on your thyroid journey or on your migraine journey. One of the most common things is starting by screening thyroid. But unfortunately, most doctors don't actually know how to properly screen for the thyroid. Or if they do, they don't actually know how to interpret the thyroid results in relationship to an actual migraine. So I'm going to go over both of those so that you can make sure that your doctor maybe did do it properly, or if not, then you know how to properly look at it and you can kind of go get retested and make sure this isn't an issue that hasn't been addressed properly. So what is the thyroid? So the thyroid is a butterfly-shaped organ in your throat that is responsible for a ton of cellular processes in our body. And it produces hormones that we'll go over in a minute that help our mitochondria work, provides energy for our cells, which in turn provides energy for our bodies. It's responsible for all kinds of other hormone and biochemical regulation. So it's really important. And, a lot of people are aware of the importance of thyroid, but just not aware of, how exactly it's impacting how they're feeling. So let's talk about some of the hormones really quickly. So TSH is thyroid stimulating hormone. This is what your brain puts out to tell your thyroid that it needs to work. The higher it is, the more your brain is trying to stimulate your thyroid, which means that your thyroid is not functioning well. And that's where hypothyroid is. So TSH will be high when your thyroid is under functioning. And conversely, if your thyroid is putting out too much thyroid hormone, then your TSH will be low or suppressed. And that indicates hyperthyroid. We'll talk about those in a minute. So TSH is how your brain is telling your thyroid to make more thyroid hormone. And then we've got thyroxine. So thyroxine is the inactive form of your thyroid hormone. About 80% of what your thyroid makes is in the form of T4, is in the inactive form. The other 20% is T3. And, I always stumble over this one, so I'm not even going to try to pronounce it, but it's a triiodothyronine. Okay. But T3. So this is the active form of your thyroid's hormone. So your thyroid will put out about 20% in the form of T3, but the rest of it is converted in your cells. So we can have a conversion problem in addition to an actual thyroid problem. So I'll talk about that more in a minute. So when we're looking at trying to figure out exactly what's going on with the thyroid, there's 4 real ways that we can have thyroid issues. One is it's not functioning well. This is the most common type of issue with the thyroid, when it's not producing enough of the thyroid hormone, and you get symptoms like weight gain and fatigue, brain fog, headaches, menstrual cycle irregularities, problems sleeping, those kinds of things. Then we have hyperthyroid, which is when your thyroid is producing too much thyroid hormone. And then that results in symptoms like weight loss, still fatigue, still headaches, still menstrual cycle irregularities, hot flashes, anxiety, those kinds of symptoms. And then we have Hashimotos. So this is when you actually have an autoimmune disease against your thyroid. So there are antibodies that are actually attacking your thyroid that results in either the thyroid producing too much thyroid hormone or too little thyroid hormone. And it will go back and forth until ultimately you kind of result in a hypothyroid state. Your thyroid's kind of burned out and it's no longer functioning the way that it's supposed to. And then we've got subclinical hypothyroidism. So this is when your labs all show normal, but you have symptoms commonly associated with hypothyroidism. It's usually the beginning stages of hypothyroidism, but is not often caught until your labs actually show abnormal, because, you know, nobody's looking out for subclinical hypothyroidism, but this can be a big reason that there can be a thyroid issue going on with somebody with migraines, but it's subclinical. And so the symptoms are going to be the same as hypothyroidism, which is, you know, the weight gain and the fatigue, headaches, those kinds of things. So you'll notice that every single condition of your thyroid issues have headaches as a main symptom of it. And then there's, diagnosis of Graves, which is an autoimmune disease that causes hyperthyroidism as well. And there's a couple other things in there, but they all fit within these 4 categories. So here's a little infographic for you. But interestingly, a study from 2016 showed that people with migraines had a 40% higher risk of thyroid problems. So, that's pretty significant. And if there's that high of a correlation, but you don't know if you've been tested well enough or even at all, definitely something that needs to be looked at, right? Another research suggests that once hypothyroidism has developed, migraines and headaches become more frequent and more severe. The problem is that, most doctors don't screen for the thyroid properly, and they definitely don't look at the subclinical hypothyroid possibility. And so that is definitely something to consider, that there's a thyroid issue, even though your labs come back normal. So what does that mean? How can you make sure that your thyroid has been properly tested? Well, first of all, let's go over the absolutely essential labs that have to be run to fully screen for thyroid function. So TSH, again, this is the thyroid stimulating hormone, a free T3, free T4, TPO, which is a thyroid peroxidase, it's an antibody, and TG, or thyroglobulin, which is also another antibody. So the last 2 are antibodies screening for Hashimotos. Okay. There are a few other labs that you can use to look at the thyroid. However, for a basic screening purpose, these 5 are sufficient. So this is all done through blood work. They're all very common labs. Your doctor has the ability to prescribe or to order them for you. They just often don't know what they're looking at when they do it. So they just usually do TSH and maybe a reflex to free T4 if you're lucky. So this is definitely something to look at to make sure all 5 of these have been ordered. So there's a couple of special instructions with having your thyroid labs drawn that, again, most of your doctors are not going to tell you to do this. So number 1, all the thyroid labs need to be drawn together as part of that same blood draw for the most accurate picture. And the exception is that if you have had, a TSH, a free T3, and a free T4 all tested in the past 3 months or so, then you can order or request just the TPO and TG, just the antibodies, to let you know if you have Hashimoto's or an autoimmune component to it. The other thing is, if you already take thyroid medication, so that's another important point that I haven't mentioned. So far, I've been talking about whether or not you've actually been screened for issues. But if you already know that you have issues, that can actually almost be a bigger problem, because so many doctors don't test labs properly to monitor good thyroid control with the medications. So if you are currently taking thyroid medication, for accurate testing, you should not take your thyroid medication the morning of the test. So it should be a first morning blood draw. You don't take your thyroid medication. You go in, you have your blood draw taken, and then you take your dosing. Because if you take your dose first and then you go in, you're actually measuring your thyroid medication not your actual thyroid function. And so we want to see what it's doing at the very lowest peak or trough, I should say, which is, going to be right before your next dose is due. And if your if your numbers are not staying consistently in the normal range, then you are not sufficiently medicated. So essentially you're still hypothyroid, right? The other thing is that I've seen this so many times that you'll take your medication, you kind of get busy, whatever, you go in for your labs at noon or 1 or whenever you have time during your lunch break or something, and you have your blood draw done and your TSH comes back as like 0.05, really low. And maybe your T4 comes back, 2.5, 3, and they're like, whoa, you are super over medicated. When in reality that you just caught the peak of what your thyroid medication is doing, when in reality you are actually under medicated, but because of those labs, they will actually reduce your thyroid medication and you feel worse. And I have seen that over and over and over again. So it is super important that you do not take your thyroid medication until after you have your blood drawn. You can certainly take it with you and take it, the minute that they've finished the blood draw, you just pop your pill and you're good to go. So let's talk about the thyroid lab ranges for the migraineurs specifically. So there's actually been quite a few studies that support the fact that T3, that's considered normal in the general population, is actually, if you're on the lower end of that scale, they have found an increased correlation of increased intensity and frequency of migraines. So for example, a common thyroid, free T3 range is 2.0, maybe 2.2 to, 4.5. But for a migraineur, they've actually found, and there have been several studies that find that a free T3 of 2.4 or less is correlated with increased migraine frequency and intensity. So you might fall within that normal free T3 range, and it is still a thyroid problem because they're looking at it in the general population and not in a migraine specific lab range. Like there's no such thing, right? We just have to go and just know based on the research that there is a lab range specific for migraineurs. So these are the ideal ranges that we want to see you in. So the TSH should be between 0.75 and 1.5 ideally. It's not the end of the world if it's out of that range, but that means that there can be some tweaking going on to help improve how your thyroid is functioning. Your free T3 should be above 3.0, but below 4. And your free T4 should be above 1.0, and ideally not much higher than 1.5. Now, a lot of times I'll see a 1.5, 1.8 of free T4 because you're on, Thyroid or some other T4 medication, and your free T3 is in the 2s. So that tells me that you're not converting well. And in that case, we either need to work on conversion for you, which is that's a talk for a whole nother time, or you can consider switching from just a T4, like the Synthroid or levothyroxine. Both of those are just T4, and you can switch over to a combined one, either a T3, T4. You can have 2 pills and have the levothyroxine and leothyronine, which is T3. Those are the synthetic forms. And then there's other options like Armour Thyroid or Nature Thyroid or West Thyroid that have a combination of T3 and T4 in it already. And then there's compounded pharmacy options. There's all kinds of different options to really hone in. There's no reason why your thyroid should not be spot on. There is a ton of resources out there from a medication standpoint. And then your TPO and your TG is the same as normal range. So we basically are looking for either a positive or a negative, right? As long as you're under that, high end, then you're fine. So how do you best support your thyroid? Let's talk a little bit about that. So with hypothyroidism, we have a few different options. There's all kinds of herbs that are really great for helping to support the thyroid. And you can probably just Google thyroid supportive supplements and see a whole bunch of them. Iodine is really good. A lot of time iodine deficiency. We don't have a lot of iodine in our diet. So iodine deficient, repleting our iodine levels can be very, very helpful in increasing our thyroid function. A general anti-inflammatory diet Hopefully you guys are all following some sort of anti-inflammatory diet anyway for your migraines. So this is probably something that you've already done or are working on. And adrenal support. So the adrenals and the thyroid actually go hand in hand, and Dr. Madison and Josette are both going to be talking about adrenals and how stress and cortisol affect thyroid and our sex hormones and all kinds of stuff, and what you can do from dietary and lifestyle components to kind of help improve that. So tune in for their lectures. And then thyroid medication. So I kind of jumped ahead a little bit in the last slide to talking about the thyroid medication. So there's natural and there's synthetic. I know that I tend to talk very fast, so I will repeat some of what I said earlier in case you didn't catch it all. There is the synthetic form of T4, which is Synthroid or levothyroxine. And then there is the synthetic form of T3, which is liothyronine. Then there's also, so those are separate, and you can actually take one or both of them. Typically Synthroid or levo, the T4 is what's prescribed, but you can also add in the liothyronine and take two of those, 2 pills to help support both T3 and T4. And then there's the natural form. So those are synthetic, those are laboratory made, not quite exactly the same as our thyroid hormones, but then you have the option for natural thyroid hormones, which is actually cow derived. And actually cow and pig, I think they take it from both. So it just depends on the source, but those are bioidentical to our thyroid hormones. So you can, if you don't do well with the synthetic, or you never can quite dial it in, you might consider trying to switch over to a natural option. And those are things like Nature-Throid, Armour Thyroid are the 2 most common, but there's also West-Throid and NP Thyroid. And then you also have a lot of options with compounding pharmacies. And a compounding pharmacy, if you're not familiar, is where the doctor can actually literally compound, like make up what they want. So I can say, I want, 25 micrograms of T4 and 3 micrograms of T3, and that's what you're going to take. And they can do extended release. They can do, not extended release, regular release. So there's all kinds of different ways that you can kind of play with the thyroid dosing. And as long as you have a doctor willing to work with you and understanding how to kind of tweak some of those medication options and compounding for you, if you're kind of more of a difficult case that just is not getting a stable level, with the regular medication that, the kind of run of the mill, then the compounding pharmacy is an excellent option. All right. So for subclinical hypothyroidism, the list is pretty much the same with the exception of the medication. So at the bottom here, I have a low dose trial. So what I usually do, if we are really suspicious of a subclinical hypothyroidism picture, what I would do with my patients is I would prescribe them the lowest possible dose of levothyroxine T4, or the lowest possible dose of Nature-Throid, which is, they can cut it in half. So it'd be 12.5 milligrams. And you try it. You just try it for a few days and you see how you feel. It's very, very obvious if you fail, if it is not a subclinical hypothyroid, because on that lowest dose, you start feeling very anxious and jittery. You can't sleep. You get a headache. You have heart palpitations. You feel very anxious. So those are all symptoms of hyperthyroid, which says the medication, even at the very lowest dose, is too strong for you. So that would be a fail. And then we know, okay, that's really the only way to rule out subclinical hypothyroidism is that low dose trial. But you can also, that would be kind of a last resort. Usually what I would do before that is all the things above it. So we would do the iodine supplementation. We would do some thyroid and adrenal support. We would work on the dietary stuff. And if that wasn't enough, we still were having a lot of those symptoms. That's when we would discuss whether or not the low dose thyroid medication trial is appropriate. Not every doctor is comfortable doing this. And there's obviously some very, you have to be monitoring very closely, and it's not something you push through, right? It's very obvious. Yes, this is an issue, or no, this is, I'm doing great with it. I feel amazing. And then you can kind of work on titrating up if you need to. So that definitely is at the doctor's comfort level. So for hyperthyroidism, whether it's Graves or not, again, a lot of the same things. So high doses of iodine actually helps to suppress it. So low and supplemental levels of iodine help to boost your thyroid function up. High levels actually suppress iodine or thyroid function. So this should be done under the supervision of a doctor. You don't just take it because you can actually end up, doing some damage to your thyroid if you're not doing it properly. But then again, there's the supplemental thyroid support, anti-inflammatory diet, medication options. And this is to suppress the thyroid rather than to give you thyroid hormone. Ablation is kind of the last resort for an uncontrolled hyperthyroid picture. And that's basically where they basically kill off the thyroid. And then you have to be on thyroid medication, like the T3 and T4 for the rest of your life, because, they weren't able to otherwise control it. But here, usually the main reason for hyperthyroidism is autoimmune. So it's usually a diagnosis of Graves' disease, and it's usually related to an autoimmune issue. And so then we want to look, instead of really dealing with the hyperthyroid, we want to look at the autoimmune piece. And again, that's a topic for a completely different day. And then there's the Hashimotos. So this again is an autoimmune condition. And so when we're looking at support here, again, thyroid and adrenal support are going to be really helpful. Iodine restriction. So studies over and over again have shown that supplementing with iodine in Hashimoto's is not a good thing. It actually worsens Hashimoto's because of the autoimmune component and the antibody's response to the iodine. So restricting iodine, anti-inflammatory diet, including a strict no gluten or dairy. And that's because the antibodies against the thyroid actually cross-react with gluten and dairy. So the more gluten and dairy you're eating, then the more antibodies are being produced, which then are attacking the thyroid. So that is an absolute must. Medications as needed, as we've kind of talked about before. Usually with Hashimoto's, we're treating a hypothyroid picture with occasional swings to hyperthyroid early on. But by and large, the majority of people with Hashimoto's actually has a hypothyroid picture. And so it basically means that, the antibodies are preventing your thyroid from producing the thyroid hormone that it should. And a lot of times medication is also needed to help kind of keep things under control. So hopefully that gave you guys some really good ideas about the thyroid, how to go about supporting it in a more natural way, but also proper ways to screen and lab testing. So I will open it up for a Q&A now, and let me know if you have any questions.